being here, I'm really excited to give this talk in front of you guys, especially being a new to PRC. I feel like I'm just speaking to a bunch of clients, but don't worry, I'm imagining you all naked right now. So my talk is called Smooth Talker, Non-Threatening PRI Patient Education. And I'm going to give you a little backstory as to why I'm even talking about this, breaching this subject. I graduated PT school in 2011, and I did an internship with Bill Hartman, who, if you don't know, is my father, adopted, of course. And he taught me an incredible amount. He was the one who exposed me to PRI. And we were just kind of getting our feet wet at that time, and I knew enough to be dangerous. And so I had a great internship with him, and I was feeling really, really good about things. I started an orthopedic residency, and so I had those tools, and I was kind of, I was already a PEC, and I had no wisdom teeth back then, so I already had a forward head, but man, I was walking around cocked at the walk, you know what I'm saying? I was feeling good, I could treat anybody. And so I got this one guy, and he had a hernia surgery. It was about 6 months ago at the time that I saw him. And there was a ton of pain there, and then just a ton of back pain and leg pain, and no one really knew what was going on. And so I was the one who treated him. I'm like, okay, man, I'm just going to go PRI right on this guy. So I started right from the get-go, doing a little bit of breathing stuff, and got from the table, and it looked like some measures improved, and I go, how you feeling? And he goes, sore. That's all he said. I'm like, crap. And being an orthopedic residency, they don't take kind of those PRI kinds, so I couldn't do that for too long. And we learned a Maitland-based model, which basically involves find the structure of fault and you do some manual intervention to correct that. And so first off I thought, okay, this has got to be muscle, So I'm doing a little bit of some soft tissue stuff, and the guy gets up, I said, how you feeling? Sore. Crap. So I guess the wrong structure that time. So then it's like, okay, it's got to be joint, and so they taught me like Brazilian joint moves, which I never use now, but anyways. So I'm trying all these different joint mobilizations, so on and so forth. The guy gets up again, and how you feeling? Sore. So, already being a PEC, my coccyx is between my legs anyways. I further go forward into that position. I said, look, man, you got to get an MRI. I don't know why. I have no idea what's going on. And so I hear back and I get the results. The scan is clean. So, you get to thinking, right? What a faker. This guy BS'd me this whole time. And so I was thinking, this is unbelievable. I had no idea, there's obviously no structure wrong. Why is it that this guy's in so much pain? And a couple months later, I took a course, it was called by Adrian Lowe, if you guys don't know that name, very smart guy, and called Explain Pain at the time. And he opened a whole new world for me. I was like Jasmine with lead on that carpet. And I figured out that's why that guy hurt for that extended period of time. And that course alone, along with all the PRI stuff, has completely changed the way I practice. And what this is all about, this talk, is creating the ideal, non-threatening healing environment. We do that with our PRI interventions, but there's other ways that we can do that as well. And if we incorporate all this stuff together, we're going to win. So I got some objectives. We're going to talk about the way that pain works, past, present, future methods. We're going to talk about the therapeutic inputs model, which is kind of how I think about the rehabilitation process. We'll talk about current educational constructs, because that's predominantly going to be our focus today. And we'll see if we can implement a non-threatening educational model for patients. All right, so let's talk about pain. We got 3 models. The very first one is the Cartesian pain model. Anybody read Rene Descartes' Meditations? And one, but it's okay. So this is kind of how traditional medicine works. Pain is sensation produced from some sort of injury or tissue pathology. And everything, if you're Rene Descartes, you love the pineal gland, that's where it all goes. So information comes in from the body, I experience pain. Or this classic example, I put my foot in the fire, pain signals travel up to the brain, and you experience pain. But as we know, this has its faults. So Rene's got some problems. How does this explain phantom limb pain? How can I have pain in an area that is no longer existent? So it falls there. It also doesn't explain emotional pain. What structure is it when your heart gets broken? Do you need a heart transplant? No, you need other things. And also pain persisting past normal healing times. Generally, most tissues in the human body are going to heal in about 3 to 6 months of time. Why is it that some people still hurt beyond that? So this is even though that it can be valuable in certain instances when there is some sort of structural issue, is incomplete. So nowadays, if you go to the International Association of, I believe, the Study of Pain or Science of Pain, this is the definition that they have for pain right now. Pain is a multiple system output activated by the brain based on perceived threat. And there was a lot of stuff that Bill talked about yesterday. It was all about threat. Pain works three ways. We have inputs, we have processing, we have outputs. So if we talk about inputs first, that's I get information from my tissues and I get information from the environment. And then another input would be your past experiences, thoughts, and beliefs that I did not write down there. But this is information coming in to my central nervous system. From that point, the information then goes up to the brain, and the brain kind of has to determine what's relevant and what's irrelevant. Okay? And then from that point, we have to determine what are we going to do with this. And then that would be the output. That would be the result. So if we look at our previous definition of pain, that it is an output. Pain is the result of whatever inputs I'm getting and then the way the brain processes those inputs. And it's really eloquently put in this model here. This is called the mature organism model. It's made by Louis Gifford, who recently passed away, but a very brilliant therapist. So we get our environment and our body tissues. Signals travel up the spinal cord. They get scrutinized in the brain, and then there's inputs within the brain. And then we get the result, which is some sort of behavior or some sort of physiological response. Okay? There's three types of pain that they're classifying as of right now. There's nociceptive, peripheral neuropathic, and then central sensitization. So I'll go into a little bit more detail about all of these. So nociception. This is what we typically think of as most pain, most of our typical aches and pain. So I'm getting noxious stimuli from body tissues. Okay? Although this doesn't always associate itself with pain. Signs and symptoms, so think about it this way. Let's say, I'm doing some curls for the girls. Boom, I strain my bicep. Okay? Ouch, it hurts with resistance, hurts when I stretch it. That's more nociceptive stuff because I have an injury to the bicep. Okay? So it acts as most typical pains do. However, nociception is neither necessary nor sufficient for a pain experience. What does this mean? How many of you guys have shifted in your seat since I've been talking? Okay, why did you guys shift?
This chair is hard.
Okay, how many of you didn't even were aware that you shifted? You just did it, right? Aside from us being PRI-minded people. The reason why you shifted is because you're getting nociceptive information from your buttocks saying, hey, you know what, you're not getting as much blood flow, you probably should move. Even though you didn't experience pain. That's normal, you're getting this all the time. Even as your bladders fill as you talk, that's nociceptive information as well, which again is not a painful experience. The other type is peripheral neuropathic pain. So this is something that is outside of the central nervous system, some sort of injury there. Those three structures in particular. How do we know that we have this? We have sensitization of nociceptors, or noxious stimuli receptors, or danger receptors, as I'll say with patients. That becomes sensitized. We get abnormal firing in the peripheral nervous system, and we get a lot of other things that occur, basically, in the periphery. Signs and symptoms. So again, I'm doing that bicep curl, but all of a sudden I start getting some numbness and tingling in the front of my arm. So there's tests you can do. You can do like a musculocutaneous nerve test, which might be sensitive. Those types of tests may be indicative that there was some sort of peripheral nerve lesion. Okay, this is the big one. This is probably the one that we deal with the most. Central sensitization. Amplification of neural signaling within the central nervous system. There's 4 types. Okay, we have first inputs equal outputs. So something is proportional. So John, let's say I punch you in the arm. Boom. It hurts a certain amount of time, or a certain quality based on how hard I punched you. Right? That's when the input equals the output. When the input is greater than the output, I punch you very, very hard. But let's say that there's a big bear coming down. You're probably not going to feel that as much. That's when the output is suppressed. I punch a certain amount, but it doesn't lead to an equal result. Input being, or less than output, or output greater than input would be I punch you and you get an excruciating amount of pain even if it was very, very light. The last one, and this is probably the one that we deal with the most, these are the people that kind of hurt with just the minimal amount of thing. I give you a light raise and it leads to an equal amount of pain. That's the hardest punishment we do. So this is the 4 types that we have. The pattern of central sensitization is no pattern. The stuff just does not make sense. You know, these are the people who are hurting just all over. Probably a lot of people that we see in terms of fibromyalgia, chronic fatigue, these types of things. This is the central nervous system upregulating as a means to defend against whatever it is was the initial threat. And then there's also the output part. So along with pain, there's lots of other areas of the brain and sensations, feelings, emotions that get activated. This is just kind of a list of them. And we also get other outputs from other systems. All of this stuff to, again, let you know that there is some sort of threat occurring. So if we kind of compare it to Renee's model versus this, we can see that it's just a lot more complicated. There's just a lot more going on with pain than just me having some sort of noxious input coming into from the periphery. So this is probably where the people who really like pain on the internet might get a little angry at me, and I'm okay with that. I think that model that I just told you is going to be dusted probably in the next 5 to 10 years. And it's because of this. We have some problems with it. We can stimulate some of those areas that I listed prior in the brain and not necessarily have a pain experience. Moreover, there's very few areas of the brain. In fact, there's no areas of the brain that deal exclusively with nociception. Now, that's only one part of the pain. And the reason why I think that this is kind of short-sighted is because that's only one possible thing that we deal with. And this place here is a perfect example. You guys deal with a lot more stuff than just pain. You deal with POTS, you deal with brain fog, you deal with a bazillion things. To me, it's all the same. It still uses this model, though, but it's just the outputs could be any possible thing. And that's where this threat matrix comes into play. And it's something that Bill touched on yesterday in his talk a little bit. So basically, we kind of have this super system within our brain that we take in all of the inputs in from the environment and our bodies, and we have to determine whatever possible outputs occur that help us stay alive or combat that threat best. This threat detection system responds to salient, which is novel input that changes the representation of what we perceive ourselves to be. So the study that I list there, the study that I list there, they took I think a laser, and they were lasering people a certain amount of time. People want to sign up for those studies. And obviously it's painful. And what they would do is they would throw in contrasting stimuli of various intensities. And it didn't matter how intense the stimulus was. It just had to be very different from whatever that person was currently feeling. That's the concept of salience. That's kind of how PRI works. Why is it a left hand, an adductor pullback so powerful? Well, because no one uses that. It's completely salient and new to them, and that's why it leads to such powerful change. So what we have to do is we have a 3-step process. We have to redirect attention with a non-threatening novel stimulus, so something salient. We have to rebuild new strategies, new motor programs to further combat threats, and then we take over the world. Okay? And if we look at it from a PRI lens, we're already doing that, right? Step 1, we reposition someone, we're redirecting attention to something different. We're redirecting attention away from the threat. The second thing, that's us building up our lift test, that's getting someone alternating and reciprocal. And then the third thing is just, training and moving on. All right. In order for us to ideally reduce threat, we have to give our individuals therapeutic inputs that are applied either by themselves to elicit the changes that we're looking for. Okay? There's 3 types of inputs that I'm going to talk about. There's intervention, interaction, and reframing. Realize the entire experience you have with a patient or with a client involves all 3, and a lot of times there's kind of some blending together of things. If we take our mature organism model, this is where I suggest that we're applying these interventions. So reframing is going to go to processing, which you can't see. The interaction is going to go to the environment, and the intervention is going to go to the tissues. So if we look at text format, therapeutic intervention is something that is tissue-based. This is what PRI is. This is what most of typical medicine is. We're trying to do something to the tissue's anatomy or physiology to elicit a favorable change. The second thing would be therapeutic interaction. This is input through environmental change. This is just, getting the patient to like you. Conversation. This is kind of the nitty-gritty stuff. It's probably the most important stuff, and I could, that's a completely different topic that I will hopefully talk about a bit more in the future. But this is huge. Oh. And then the last thing would be therapeutic reframing. And with this, our intent is to change one's thought processes. This is how psychology works. This is what happens when we educate people. This is what happens when you learn. So, if we're dealing with a patient or a client, and the input that, or the thing that is threatening most for that individual is one's thoughts or beliefs, what are we going to use? We got to reframe. So how do we do that? Let's talk more about fear before I tell you guys how to do that. These three things right here are going to kill any program if your patient has that. Strong correlations of pain and disability. There's a very cool phrase in this study by Arntz and Peters, which, we've probably all heard variations of this, but the fear of pain is worse than fear itself. But remember, we're dealing with a threat detection system, so it's not just exclusive to this. How about this one? The fear of POTS is worse than POTS itself. Or how about this one? The fear of constipation is worse than constipation itself. Sorry, wrong topic. It doesn't matter, right? What are you guys doing to address the fear? So, I love PRI. It is the foundation for what I do, and it's changed my practice for the better, and it continues to do so. That's why I keep giving Ron Rusk all this money to go to courses. This is very important, but we're not going to do that today. What I want you to do, you guys all have the PRI exercise CDs, right? Okay. What I want you to do is pull out your exercise CDs, and you're going to go to the right amygdala inhibition section. I think it's in the pelvis one, actually. And I want you guys to pick standing number 1. And so that is standing unsupported therapeutic neuroscience education with non-threatening patient-friendly language. I don't know why that guy's shirt was off, but I just, why not?
It's not right. Go to the man with no gloves.
So what we want to do with this case is we want to provide education that alters these undesirable beliefs that patients may have. So you're probably wondering, Zach, is this within my scope of practice? You're asking me to be a psychologist? Well, let me ask you this. If we are the movement experts and fear or anxiety or catastrophization is limiting one's ability to move, why can't we address that? I say that's totally a part of our practice because we are impacting movement in a favorable direction. We're probably just not using the traditional methods that we're used to. So, you're not a psychologist, but you're a psychologist. All right. So let's talk about some educational models. So guess what? We kind of stink at it. It doesn't really work. Why is that? I would argue that it is because of the model that most of these studies here that I cite are using, okay? Which is the biomedical model. So we find some anatomy, we find some biomechanics at fault, we correct it, life is good. However, it has very limited efficacy in decreasing pain and disability alone, all right? And moreover, it's increasing these bad boys, which we had shown in some of the prior slides that I mentioned, lead to worse outcomes. This slide here is huge because a patient's beliefs, coping strategies that they use are going to have a huge impact on their outcomes. These can be large determinants in one's chronicity, okay? And it's what's keeping healthcare dollars up. This quote was very powerful for me. A number of factors influence the participants' beliefs, but what you tell them is most important. They, believe it or not, they take what you say very, 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 very seriously in most cases. In this study that I cite right here, a simple diagnosis such as an ankle sprain will completely change how that individual moves if they're given that. Moreover, whatever model that person is accepting as this is why I am feeling X they're going to use that throughout the remainder of their life if you got them and if that's the first thing they've been exposed to. How many of you guys have used words that are right here before with a patient? I know I have, and I do sometimes. I'm really trying to break this habit. What this study did was they took I believe it was like 20 patients, and they had them work with clinicians, and they basically laid out what effect did these words that these clinicians use have on you. And if I use these words on the left, not only do patients not really understand what that means, but it may lead to a negative outcome, or at least a negative thought process, just based on the words we say. These guys right here, things such as muscle sprain, strain, alignment, and posture, also very unclear, but may not necessarily lead to a negative outcome. It just really depends on how that patient perceives those words. This stuff right here, not so bad. So, muscle spasm, sensation, all of these things, people get that, they understand what that means. This next piece right here, on this end we have, this is what the clinician said, and on this end right here we have, these are the behaviors that the patients were using, and this was acute and chronic low back pain. So if we're talking more about we have to protect the area, and we discuss a lot of these things, muscles, avoiding movement, and posture, look at the results that these patients have, or at least how they're perceiving what you're telling them. So they get guilt, frustration, and worry. But how many of us are doing this, saying it's okay? If you add that into the mix, boom, large changes in outcomes, and they know that they're going to be okay. I thought that.
Hey, Zach?
Yes.
Go back to that for just a minute.
Absolutely.
Is that in there?
I will put the PowerPoint up on my website. So
Is that in your list of references?
it's also in my list of references, so it's the Darlow one. And if any of you guys email me, I will get you any of these articles. And I can write you my email too. That's very good study. But out of all that, this was probably the most powerful thing that I had read in a lot of these studies. So let me give you a bit of background about this. This was an individual with low back pain who had spoken to a provider and was given an alignment-based educational model as to why this individual was hurting. So I'm going to go ahead and read this. When the current episode first happened, the only thing that was going through my mind is the seriousness of my disalignment of my back. I was really petrified. You get scared in the sense that you could damage your spinal cord or anything to such an extent that you might become paralyzed. If this is what your patients leave with when they're done under your care, you may as well stretch their left hamstring because this is pathology. And unfortunately, there's not a ligamentous muscle that's going to fix that. What model are we using as PRI clinicians to educate our patients? And is this a favorable way to address processing? It may be or may not be. It's just going to depend on the individual. But we have to really be careful about the words that we choose when we're talking with our patients, because we don't know what impact that's going to have on them a year later, 5 years later, 10 years later, when they're at the end of life. Because that model could be something that they're going to utilize for the rest of their lives. Most patients want to know more about pain than anatomy, and this was one thing that I had picked up at Explain Pain when Adrian taught me. It's like, that's all that my residency had told me to teach these people about. But how often do we talk about what pain is and how that works? And moreover, if you explain it in a simple manner, patients can get it. They understand pain science. And moreover, it works. It's got a lot more research that's coming out that's showing that this is more effective than what the current models are that we use. Favorable ratings and decreasing pain efficacy loses how well it works at 3-month follow-up. And the reason why I think that is it's much like our repositioning techniques. You can get someone neutral all you want, but if you're not building new programs on there, it's not going to do any good. This is the same thing. It's a repositioning technique for your beliefs.